All right. Thank you, Dr. Gard. So we've already gone over a little bit with Dr. Shavitz's presentation, and
Hey,
I.
Dr. Gard's my dad. I told you this. So
That's true.
yeah.
But yeah, there's so all the slides that you guys have before. I'm gonna list all these studies. So there's definitely some repeats here, but just kind of go over my rationale for the difference when I'm choosing adipose versus bone marrow and kind of the science behind that. So here are the learning objectives, just kind of compare adipose derived versus bone marrow derived. And then I'm going to say stem cell, but like we were talking about before, the MSC, well, I'll actually get into it because I have a slide on that. But if I'll say stem cell just because it's up there, but we're talking about, you know, medicinal signaling cells is the preferred nomenclature for both the bone marrow derived and the adipose derived, and just some of the differences there. So you know, this has been going on a while. I think I started lecturing here in 2018. So I've had kind of the slides that I've been using that kind of gave a narrative as it went along, but some of them are just, oh, this is the first case series, this is that, so it's not essential that you guys know each one of these studies, you know, front and back. So yes, we used to call them mesenchymal stem cells, now medicinal signaling cells. In the US, we can really only do, as far as adipose goes, MFAT. We can't isolate with, you know, like SBF, where you get rid of everything else besides the MSCs. We can't culture expand, but they can obviously do that in some other countries. And then, you know, as far as bone marrow, we get BMC or BMAC, or BMA is the bone marrow aspirate. So really with adipose, just scientifically on paper, there's a whole lot more MSCs per milliliter with that. I think there's lower morbidity. I've done a whole bunch of the liposuction, and you know, it's a small little incision. You're not really going through the bone, so I think it's less trauma on the patient. And then there's more stem cells per milliliter, more MSCs per milliliter, and then there is a trend, you know, at the age of 20, there's a whole lot more bone marrow MSCs than there is when you're 80. So there's definitely a sharp decline with the bone marrow, where it's pretty stable with the adipose derived MSCs as we age. So, you know, why do I mainly do adipose? Easy to obtain, you know, not a lot of morbidity, higher cell counts, and the limited decline. And then I really like it as a matrix, so, you know, if there's a rotator cuff partial tear, I can inject and watch it just kind of fill that defect and it stays there. Where when I do a PRP or a bone marrow, it just kind of flows everywhere. So it has that matrix. So both bone marrow and adipose are derived from the embryonic mesoderm. They have a fibroblast-like morphology, and both of them can really, in vitro, which is not what we do, you can get either one of the cells and grow out any line of tissue that you want. So they have all that same basic information. So this was kind of the first study that showed that. So this was 2001, where they could process it and grow the different cell lines. This slide kind of goes over how many MSCs per milliliter in the adipose, you know, versus the BMA. So not concentrated, but BMA, and not the needle that he was talking about, just doing the one draw of 100 milliliters of BMA. So again, this was the first case series. So back when I was first presenting this was, you know, the first case where they really showed it. This is SVF. So obviously that's different, and they combined it with HA, PRP, and see that nanogram of dexamethasone. That's not a true steroid, that's just trying to stimulate that. Then they actually did 4 additional PRP treatments. And then, you know, this was another one in 2013, you know, a few more patients with NEOA. Again, this was with SVF and PRP with 2 repeat PRPs, but they did a big 2-year follow-up, you know, where the pain went down and the functional scores improved. And that's what a lot of it was, you know, at the beginning. I got 10 patients, 20 patients, 50 patients, you know, they're all getting better, a majority are getting better, so we started seeing the trends. And then they started to do kind of arthroscopic first looks and second looks. Like I said before, we're not telling our patients we're regrowing all their cartilage. You're asking me about the meniscus before. We're not saying we're going to heal everything. I see a lot with tendinopathy where I can see on ultrasound or repeat MRI that it's really filling in the gaps, but some of the avascular structures like the meniscus, like the cartilage, you know, we're not guaranteeing that those are regrowing and healing as far as that goes. But there are some examples like this where they see a defect before, and then they see, you know, some cartilage smoothing it out and growing back in. So on those second look arthroscopes, they definitely saw either maintained or improvement in how the cartilage looks. So this was one of the biggest studies, you know, back in 2015. So they had, you know, over 1,000 patients, both knee and hip, all 3, grade 2, grade 3, grade 4. They broke it down by BMI as well, and about half of them were candidates for, you know, total knee or total hip arthroscopy. And then, so we did at 1 year, you know, 75% score improvement, which is pretty huge, and, you know, almost 60% of the patients, and then in 90% of the patients, they got at least 50% improvement. And that's what you gotta, if you guys do a study, you have to set, okay, everyone that gets 10% better, or 50% better, or 75% better. I mean, the study director or whatnot, the program decides that, but, you know, if you want significance, you gotta have a reasonable outcome. So what I've done in most of my studies is at least 50% improvement in function or 50% reduction in pain. But of all those people, what was it? You know, we had only, oh, I'm going the wrong way, I'm sorry. So of all those patients, over 1,000, only 4 of them actually required total joints, you know, as they were followed there. So this is 2017 Hudetz. This is 17 patients. The interesting thing about this was they did the gadolinium enhanced MRI, so it's another of the function of the cartilage, the health of the cartilage. So they did, you know, a repeat one at 1 year, and, you know, over half of them saw improvement in how the cartilage was reacting and how it was functioning. So that they did the pain score at rest was, you know, 85%. With moving, it was over 50%. So showed some good improvement. You know, another case, retrospective case series that, you know, followed the function, the pain improvements, you know, over a year. So at least 30-point improvement in the VAS score, and 50% of the patients. You know, 2/3 of the patients got at least 10-point improvement in their function. So very good improvements as far as that goes. And then they did this is the same study, they just extended it out 3 years and pretty much either increased or maintained those trends up to 3 years. And that's the thing, there's a lot of studies that compare steroid to PRP to, bone marrow or adipose, if they're only a year, PRP versus bone marrow, PRP versus adipose, really not gonna show that much of a difference. It's usually at 2 years, at 3 years, up to 5 years, where you can see the general trends where bone marrow adipose is maintaining that and PRP is doing well for a year or two and then kind of coming back down. So the 1 year studies, and I'll talk about it later, they are kind of, it's kind of tricky. Or you do a 3-month study, and with cortisone, you're probably gonna see the exact same results as you are with PRP or one of these treatments if it's just 3 months. But we're not after 3 months, we're after as much time as we can buy our patients as far as that goes. So this again was one of the first randomized control trials that showed for partial rotator cuff tears, they did it versus steroid at a year. So again, beginning it looked pretty much the same with the steroid as the adipose, but when they did the repeat MRI and the functional scores that were different, they could actually see less of a tear, the healing of a tear with the adipose versus an increased tear. So if you're injecting, doing a subacromial, I mean, hopefully most people don't inject directly into the rotator cuff, but that's still making those tendons weaker if you're doing a steroid. So it's not just, you're actually doing a little bit of damage, even though you're calming it down a little bit with some pain control with the steroid. All right. So this is MFAT versus PRP for knee arthritis with two-year follow-up. Oh yeah. So this is one study to look at. Dr. Mottner and Emery did another study comparing MFAT to BMC, which basically showed no difference. They both improved with pain and with function, and then. And then you've already gone over a lot of the bone marrow studies, but Hernigu is kind of the gold standard. So what happened is he was in a big hospital system, and they forced him, because he was doing stuff that no one had ever done, they forced him to really follow up with all his patients. So, a lot of it was him too, but a lot of it was the system that he was in was making him do all these follow-ups on patients. So that's kind of the longest term, best data as far as the bone marrow concentrate. So you have all those studies. The slide on the right is really all the safety behind it. And so if you're using good technique, and we'll go over it all in the lab, and you know where you're going, all these treatments, the adipose, the PRP, and the bone marrow are extremely safe. Not a lot of infections, not a lot of morbidity, again, because it's all autologous. So this was, I think you mentioned this one, 15-year follow-up after the subchondral, for the interosseous injections. This kind of goes over 15-year follow-up. That's where they had one knee with the TKA, one knee with that, and almost all the patients preferred the bone marrow treatment as opposed to having metal and plastic in their body with the TKA. All right, so Regenix has done a lot of tracking too, Dr. Centeno, so they have a good database of this. They prefer bone marrow over adipose there. They've asked me multiple times to join up with them, and I'm saying if I can do adipose, I'll join up. And just recently, not like I'm going to join them, but just recently they have started to incorporate some of the adipose in some of their clinics. But all I'm saying is they have very good data as far as follow-up with the bone marrow. So yeah, we're seeing significant improvements in both pain and function at 12 months, at 24 months. So almost 90% improvement was sustained, even at 2 years out with that. Dr. Buford did a great one on partial thickness rotator cuff tears that came out a couple years ago that was showing, a decrease. So they started at about 6 on the pain scale, and they're, under 2 at 1 year, at 2 years. So that's really showing, you know, sustainability following these procedures. Obviously, we'd love the 15-year follow-up on every study. It costs a little bit of money, and you know, it's not really easy to do that with all their patients, and that's the thing. Patient does well, especially if you're just calling them up or having someone text them or whatnot for these follow-up surveys. You know, I don't know if I would take a call every year for 15 years, like, yes, my knee's still good, yes, my knee's still good, but that would be ideal in some of these scenarios for knowing the long-term outcomes as far as that goes. So there's some great studies for bone marrow for AVN, you know, particularly the femoral head, where it's really showing kind of regrowth of that. You know, we're not getting full expansion, but avoiding the hip replacement as far as that goes. So I put a bunch more studies up that will just kind of complement you and see where the research is. Some are comparing, some of them are basically doing systemic analysis of all the studies that have, you know, adipose versus all the ones that have bone marrow. But really, what do you use? PRP, BMA, BMAC, or adipose? I'll just tell you right now, every adipose case I do, and every bone marrow case I do add PRP. So I'm super concentrating the PRP, you know, down to 1 or 2, and then, you know, filling in the rest if it's a knee or a hip with either the adipose or the
Same. I do the same
Yeah.
thing. Yep.
Yeah. Jeremy, same?
Same.
Yeah. All right, so this is just kind of a slide kind of showing, and again, this is more in vitro stuff, but the differences between the adipose derived versus bone marrow derived. So, you know, if you're doing AVN of the bone, probably want, you know, BMAC, or you're doing interosseous, you either want PRP or BMAC. You know, like I said, some people are really good, easy, you know, with the bone marrow. It takes me a little bit less time, but again, you're tapping, you're causing a little bit more trauma. Doesn't hurt that much because we numb it up, but some of the patients are a little apprehensive to do that. And I've never said, oh, I'm going to take a little fat, and someone's like, no, don't take my fat. Everyone's always like, yes, take more, or the wife sitting next saying, take mine instead. So, yeah. Yes. But also you have to see, you know, with some athletes, you know, that I've wanted to do adipose on, there's, you know, nothing there. I have had a few high-level athletes that have actually gain weight for like a month, gain like 5 pounds, so I could take some out, and then obviously they're gonna go off it afterwards. But you know, that's kind of the art here, where you're saying, all right, I can do what I can do, but you gotta work with what you have as well. So for bone marrow, you know, which patients, like comparing PRP to bone marrow. So I'd say for more grade 3, grade 4, I'm gonna, you know, do bone marrow with PRP. Obviously the OCD lesions, the AVN, the stuff that's more cartilage, bone rather than tendinous, you know, I'm looking more towards that. There was that great study for the partial thickness rotator cuff tears, but to be honest, I would rather, you know, do the adipose there where I can see it stick right where I want it. But then obviously thin patients that are not great candidates for doing the MFAT. All right, so this is another Montner study where they tried to see, you know, the difference between everything. They had amnio, or the umbilical cord, cortisone, bone marrow, adipose, and they really showed not a huge difference between, you know, the bone marrow and the MFAT. So Dr. Beria put out a study basically, and this is what I was talking about before, microfat versus PRP. I would expect the same thing at 1 year as far as that went. I'm going to show on another slide where there were a lot more 1s and 2s in the PRP group and 3s and 4s in the MFAT group. So it wasn't like completely randomized. But yeah, that basically showed no difference between PRP and MFAT at 12 months. So again, this is a different study by Hoffman that's went the same thing for PRP versus bone marrow aspirate, 1 year, so same thing. You know, you're not seeing a whole lot of difference at 1 year, but then we get to 2 years, 3 years, 5 years, then you're seeing, you know, that sustainability of the MSCs versus the PRP alone. All right, so this was that systemic review that kind of broke down. I don't know if you guys can see that, those 4 different studies. So, you know, I'll just kind of break it down. Watner study compared, you know, MFAT to bone marrow, no significant difference. So that's what we care about most, is their function, their pain control. So we're really good kind of either way, using either the bone marrow or the MFAT. And so again, the other studies were either, you know, more patients that were the worst grade were getting the MFAT or BMC versus the grade 1 through 3 with the PRP, so it wasn't exactly, you know, an equal study. Again, with Dr. Berry's study, it was just 1 year, very small sample size, but still, they did more lower grade with PRP versus higher grade with the Adipose. And then Zanfrini study, it was more evenly distributed, and that they were equally effective for grade 1 and 2. This kind of goes with the theme. For grade 3 and 4, MFAT really outperformed just PRP. So there's a lot of studies going on now that are comparing MFAT to bone marrow. The one I'm most excited about is a group called Rizzoli out of Italy. They just published, like, we're about to do this and put a paper out, but no actual stats. So there's a lot coming out now and in the future. So a lot of people are doing the studies I've always hoped for, randomized controlled trials comparing these. So real quick, we'll show you a lot more in the lab, but you know, as far as the procedure goes, you kind of want to plan it out, make sure they have enough, plan out where you're going, you know, different harvest locations. She doesn't have a lot, but that was the only picture I could find that kind of maps out. But really, we're either going abdomen or love handles. I mean, I have done the outer thighs. I haven't done a lot of inner thighs. I've definitely not done any arms or shoulders. So really, we're going abdomen or love handles. So you can do this in your office. You can do this in a procedure room. You know, obviously, if you have a surgical center or OR, you can do it there. I used to be, you know, full scrub, like walking in. My assistant would have everything on. I think I was definitely overdoing it as far as that goes. You know, a lot of people want to square off everything. Obviously, sterile gloves, but you don't have to go to that extreme. So I'm going to be doing a procedure. It's going to be in here later on, but basically, you know, we're doing a little numbing, using an 11 blade, kind of an 18 gauge to make sure you have good access there. And then whatever system you're choosing, we're going to do the MAP system today. I've used probably every system there is out there, and that's the one I like the best currently. But you need for the solution to kind of numb everything up and loosen everything up, you basically using lidocaine 2%, you know, a couple ampules of epinephrine, and then again the sodium bicarb really buffers that, so it's not doesn't give them that much pain. So I mean, this is just a little shot. You're going to see it more live. So that's the 11 blade. Obviously they're already numb, so I usually do an 11 blade and then get an 18 gauge just to make sure there's not fibrous tissue, you know, kind of blocking the way so the cannula goes in there. This video is obviously me in full gear, and my assistant as well. This is a 3.5 millimeter size cannula. Now the one I use is a lot smaller, so I haven't been doing the 18 gauge as much, but I'm still using that 11 blade. And basically I'm infiltrating you know, at this point, and then we'll be harvesting a little later. And then after you harvest, there's different techniques to micronize it, to filter it, to get out. You know, there's the lipogens where you're doing a little martini shaker. There's different systems like Joint Tech that has 20 different things. But really, we're just trying to get the cleanest, the purest, but we cannot digest, you know, as far as the rules go, we cannot culture expand. So really it's getting that material in hand and trying to get rid of the red blood cells and the oils. You don't want to inject the oils in with your injectate. So, you know, I used to use just a little tulip filter, but I'll show you guys the one I use. Alright, so this is just like a 1.6 millimeter filter going back and forth, and then the size of your syringe when you're injecting is important too. If you're using a 20 gauge syringe and trying to get that into a 25 gauge needle, it's not going to work well. So if you use a 1 cc syringe, you don't have to use a huge, you know, 18 gauge needle. You can do it, you know, sometimes 21, sometimes 22. So, but on the other hand, you know, if you use an 18 or a 20 and you want to just get the whole thing in, it's really kind of the feel of it. And, you know, I popped a few. I'd rather pop a 1 cc and it goes everywhere than a bigger one. But that's kind of the standard that I use. We'll show you the injections later, and yeah, we're getting a little close to lunch. We still have 20 minutes right now to kind of go over any questions that you